everyone over there for having given us this opportunity. I should also thank Dr. Carlo as well as Dr. George Dangas for being with us tonight. Here it's around 11 o'clock in the night. I shall quickly take you through the case. Can you enlarge the fluoro monitor? This is an elderly gentleman. Almost 10 years ago, he had undergone an angioplasty to the right coronary artery. The mid-right coronary artery has a long expedition stent. So he has a long expedition in the mid-right coronary artery, which was implanted around 10 years ago. And he also had a mild disease in the left anterior descending artery, which was kept for medical management. Of late, he had effort angina, and 2 weeks ago, his treadmill test was positive, and he was taken up for angiography. And this was the angiographic images. You could see here that the right coronary artery is flowing well. It has got mild disease. The stented segment looks good. The flow is good. You could also see in this view that the LED is seen retrogradely filling from the right coronary artery. The next image. That's the cranial image. Again, you could see that the right coronary is reasonably good, and the left anterior descending artery is a type 3 vessel. It's retrogradely seen from the right coronary artery, and you could also see that there is a large diagonal there, and beyond the diagonal branch in the LED, there appears to be mild diffuse disease. However, in this view, there appears as if there is no critical stenosis of the left anterior descending artery beyond the diagonal branch. Next image. That's again the same information. That's the right RAO view. Again, making us understand the same information. There is little bit of calcification at the site of occlusion of the left anterior descending artery. Now we'll go to the left images. When you look at the left coronary shoot, you could see that the left main looks reasonably okay. The ostial LED has got a tight stenosis, which is actually extending into the proximally into the left main also. And the circumflex looks reasonably okay. There is an intermediate stenosis in the mid circumflex artery. And you could also see that beyond the diagonal branch, the left anterior descending artery is totally occluded. So next image. The next image, the AP cranial did not give us a lot of information. Next image, that's the RAO cranial image. In the RAO cranial image, you could see that the LED is totally occluded right at the bifurcation. The first diagonal appears to be a smallish branch. It's around 2 millimeter in size. However, the second diagonal, which was seen retrogradely, was looking quite big. It was 2.5 millimeter in size. So that is the angiographic images. Next one. That's again the spider view. The LED ostium looks significantly diseased and it's extending into the left main. Next image. Well, that is how we started off today. Would you like to discuss before we go ahead with regarding whatever we've done till now? Would you like to discuss about the case prior to we starting off with our strategy?
Yes, certainly, Dr. Davidson, and thank you for showing these very clear images. So he's a relatively young patient, single vessel disease, excellent result, few years after a stent in the right coronary artery, but now there is disease progression and the occlusion of the mid-LAD. There is good feeling mainly from the collaterals from the right coronary artery, and I had the impression in some views that there is a stump at the level of that mid-LAD, so maybe we can consider an anterograde approach without necessarily going for IVOS guidance. But we have obviously our expert colleagues here in the room, as well as George Dangas, so maybe I'd like to have his opinion on the case.
Well, I think this is a great result, first of all, in the RCA, so that's definitely very encouraging for this patient. This means has a favorable response, vascular response to angioplasty and stent. Is actually the tremendous collaterals that allow you visualization of your distal target vessel. I do agree there's a little bit of a stump there. Right after the first diagonal. On the other hand, talking about precision PCI, I would probably say that an assessment of the circumflex lesion would at some point be in order as well, because it seems to be intermediate, about 50%, but it's a very large vessel, so it may end up being somewhat ischemic, although clearly not a major target of this case. So let's see what you've done though, and then we can come back and then see what we think about those things. But I would probably favor also the antegrade initial approach.
Yes, so our plan was we have a left main bifurcation stenosis, which we felt that a provisional strategy would be fair enough. The circumflex ostium was looking good, and then regarding the CTO, we felt that both with the retrograde, we'll go antegrade approach. We'll have a catheter in the right coronary artery to see the retrograde collateral flow. So we started off through the femoral approach with a 7 French EBU 3.5 guide catheter. Next image. We had a simultaneous injection from the right as well as left. That is what you had been seeing till now. And the length of occlusion, it was looking almost 15 to 20 millimeters. And you could see that there appears to be some amount of calcification also over there. Well, so we started off with a microcatheter and a Versaturn wire. We with the help of a Versaturn wire, we tried to probe that particular lesion, and we made out that the wire wouldn't go through. So we switched over to a Fielder XT wire, hoping that the Fielder XT might go through. That's the Fielder XT wire. It was buckling over there. It wouldn't cross the lesion. Next one. Then we switched over to a Gaia wire. Next image. That's Gaia 3. With the help of Gaia 3, we were able to get across the lesion, and the wire, it went into the diagonal branch. And this was confirmed. This was confirmed with the help of a contralateral injection. And once we saw that the wire was inside the diagonal branch, we pulled it back and wired the left anterior descending artery. And once we were distally inside the vessel, we took out the catheter from the right coronary artery. Next image. Fortunately, we were able to get across the lesion with the microcatheter. Next one, that was a fine cross, and then we exchanged it with a Versaturn wire, and then we did dilatation with a 2.5 millimeter non-compliant balloon. Next image. Next one. That's the image that we got after pre-dilatation of that particular segment. Now then we decided that we'll go ahead with an OCT evaluation. We gave some nitroglycerin prior to OCT evaluation. Next image. So that's the OCT run. We took a long run, that's a 75 millimeter long run from LED. Okay, now we'll come to the OCT. Before I go to the OCT images, would you like to discuss something regarding this?
Great result, great result. I mean, now we turned the CTO, we turned it into a bifurcation of the ostial LAD. That's great. And also there are multiple bifurcations, quite frankly. 1-1-0, so to speak, bifurcations. The side branches are not involved, but there are many side branches worthwhile preserving. Diagonal 2, diagonal 1, as well as a circumflex.
Yes. Dr. Kannan as well as Dr. Selmani is also with us in the panel. Would you also like to opine?
Yes, Deepak, it was good that you had a wire escalation done, and you could draw across with the Gaia 3 there. And to start with, ostial LAD also has a disease, and definitely I think you need to look into the left main and then decide the strategy. And as he already pointed out, many branches, D2 and D1, all significant size branches, we'll have to preserve it. So we'll look at the OCT and take a decision how you are going to approach. Predominantly, we'll look at the distal left main ostial LAD, and then we'll look at the D1 also, how the angle is, and then we'll take a call.
Okay, shall I?
Great. I would like to see the OCT, and then we can ask again Dr. Selvamani to see which one of those great cases he showed us. This one fits the most. Let's go with the OCT. That's great.
Yes. So we had actually positioned the OCT catheter well beyond the bifurcation. That is, this is the D2, and the OCT catheter was positioned well beyond the bifurcation.
Yeah.
Based on the angio, the retrograde collaterals, we had a feeling that the distal LAD is significantly deceased. However, it was not critically deceased. If at all we had to stent that particular area, we'll have to put in long stents right from the left main into the most distal LAD. So we felt that there should be some amount of we felt that this vessel should grow up once we open up the proximal portion. So based on the angiography, the retrograde collaterals, we felt that probably our stent should be probably parked proximal to the D2, this particular branch. That is what we had in our mind when we started off with the angiographic images. Well, you could see that the catheter is well inside the distal vessel. These are areas wherein you could see that the 3 layers of vessel is seen. However, at 11 o'clock position, you could see that there is pathological intimal thickening, which was acceptable for us. The lumen area was 2.79 beyond D2 branch. And as we come more proximally, you could see that there are areas of significant neo-intimal hyperplasia, and that's the diagonal branch. Well, if you look at this particular diagonal branch, the ostium of the diagonal branch looks good. The angle of the diagonal branch also looks good. So if you were to position a stent well across this particular vessel, the chances of this closing down would be very unlikely based on the OCT criteria, because the angle is a wide angle. It's not a narrow angle as well. The BPCT length is also good. So if at all we had to position the stent beyond this particular branch, we are unlikely to lose this particular branch. Well, now as we come more proximally, based on angiography, this is what we had in our mind. Probably this is the area where we should park the stent. So looking at that particular area, the lumen appears to be 4.15, and there is no significant lipid pool over there. And when we looked at the length, when we looked at the size of the vessel, it was almost 3 millimeter in size. So that's what we made out based on the OCT beyond the lesion, but proximal to D2. So that was the area which was definitely deceased, which there is definite pathological intimal hyperplasia. However, there is no lipid pool. So based on this, we again thought that this should probably be the landing zone. We wouldn't want to go beyond the D2 branch. That's what we had in our mind. Well, as we come more proximally towards the area where we had the total occlusion, you could see that at 7 o'clock position, there is some amount of calcification. As we come more proximally, you could again see that there is calcification, but it's all islands of calcification. There is no area of calcification which is actually coming to more than 90 degree or more than 180 degree arc. So there were islands of calcification which we made out in the fluoroscopy also. So again, you could see that it's more a fibro-fatty area. This particular area alone, you could see that there is almost 180 degree arc of calcification. So that's the arc of calcification seen from 9 o'clock to 3 o'clock position. And as we further come proximally, it is more a fibrous lesion, and you could also see the area which was dilated, the dissected area with the help of the balloon. And as we come more proximally, again you could see that there are areas of calcification. And as we come further more proximally, I'll come back to the ostium of the LAD. That's the we are near the ostium of the LAD. That's the ostium of the LAD. You could see the circumflex in the longitudinal view. So when you look at the ostium of the LAD, the ostium of LAD is significantly diseased. The minimal luminal area is only 2.8 millimeter square, 2.2 and 2.8 millimeter. It's significantly on the lower side. So it's for sure that we need to do something for the LAD ostium. And as we come more proximally into the left main, you could also see that the left main is also significantly diseased. You are not able to see the 3-layered vessel in the left main, except probably in 4 o'clock position you are able to see the 3 layers of the vessel, but rest of the area it's all diseased. The left main is also diseased. As we come more proximally, there appears to be a small calcific nodule over there. So that's the left main, and when we measured the left main was 4.5 millimeter in size. So based on all these images, what we had in our mind was the distal vessel was looking almost the distal landing zone was looking almost 3. The left main was looking 4.5, and there is no significant circumferential calcification. So the non-compliant balloon dilatation would be fair enough. And then probably we should park the we would stent with 2 stents, probably with a 2.75 in the distal segment, even though the vessel was looking 3. Because it's a deceased vessel, we thought that we should go with a 2.75 millimeter stent in the distal segment, and then probably overlap it with a 3.5 millimeter stent way back into the ostium, almost till the ostium of the left main, because the left main also was looking significantly deceased. So this is what we had in our mind based on the OCT imaging. So can I have suggestions from your side?
Oh, you're going to have a lot of suggestions. Let's just ask Dr. Selvamani, was any of the OCT calcium deep calcium, and how deep, significantly deep, or is mostly a superficial or just even a mixed calcium? What is your assessment of this complex OCT assessment, Dr. Selvamani? You gave us a tremendous talk before.
It is predominantly a mixture of superficial and deep calcium. And there are few areas of lipids also seen there. And it's predominantly, there is no concentric calcium there. So the main implication of this is you may not require a special device like IVL or ROTA for this. It is, you can crack it with an NC balloon. Maximum probably you can go for a scoring or a cutting balloon, if at all, if there is no lumen gain there. But most of the time, such calciums can be treated with NC balloon dilatation, as Davidson himself has also suggested that. And of course, looking at the other features of bifurcation there, the angles are all favorable. And definitely distal left main as a disease, probably we'll have to treat that also, including that, treat it as a crossover from the left main into the main.
So what was the diameter of the balloon that was used initially?
Well, let's hold on for a moment because I have some more comments, I think. Carlo, at least I learned a lot from the OCT. I was suspecting there would be high degree of a lot of calcium at the culprit occlusion. And at least angiographically, fluoroscopically looked severe. And I agree with the interpretation of the OCT. I'm just saying I was surprised. Like, I think we learned a lot from the OCT. Otherwise, I would say there's tremendous calcium at that area, which apparently not that much. Weren't you surprised too?
Yes, I am. There has always been a reluctance among CTO operators in adopting widely OCT because the power injection required to have good images sometimes may risk to enlarge dissections. Here was so obvious that was anterograde true lumen crossing that I think there was no real issue, and the OCT is certainly the best technique to assess calcified stenosis. If you apply the 3-5 rules here, you don't have any indication for a lithotripsy or rotablator or anything of that sort. And I agree with the decision of avoiding this very diffuse distal disease, which in part is also due to under dilatation of the distal lumen, because under pressurized for years being filled only by collaterals will take time to regain its normal size. I had the impression was a little bit underestimated the size at the occlusion of the vessel is probably 3.5, at least in that elliptical area in one of the two measurements of media to media diameter. Still, I think that the choice of being a bit undersized with the stent to start distal and use a larger 135 going from the proximal leading to the left main is very wise, and I've seen a wire protecting the circ, which is definitely the most important vessel to do. So I see a long stent going to be implanted. We have another 20 minutes. I think we should let them go ahead and see how it comes and then discuss the result once we see what comes out of it. So please go ahead.
So at this point of time, we took a 2.75 alpine. which is 33 millimeters long.
Deepak, just one doubt.
Yes, sir.
Didn't you dilate further? You just were
So
happy
we
with the
went up
initial
to
dilatation?
2.75 balloon.
Yes.
Yeah.
Yeah, you have dilated with 2.75.
Yeah, and
The
the stent
area
is
where the
also 2
calcium was
points.
there.
Pardon me, sir?
Yeah, you dilated the osteum also, isn't it?
Yes,
LED osteum
yes,
also.
yeah, yeah. Now,
Now,
But the calcium was mainly limited to the area of total occlusion. The where
yes,
we
sir.
had the
Yes,
total
sir. True,
occlusion,
true, very
the
true.
calcium was mainly at the total occlusion.
Yes, very true.
And when you dilated the balloon, the waist gave way relatively easily, right?
Yeah, even at 10, 12 atmospheres, we were able to open it up.
It opened up.
Yes,
Okay, then that means we are having a relatively good position now. Please
yes.
go ahead.
So
yeah,
that's it.
yeah,
2.75 millimeter alpine. Next image, we went up at 12 atmospheres. We deployed the stent at 12 atmospheres, pulled it back, pulled the balloon back a couple of millimeters, and went up to 16, 18 atmospheres. So that's we pulled back the balloon and went up to 16, 18 atmospheres, and that's the result that we could achieve. We definitely have in our mind that we would go ahead with a 3 millimeter balloon for post dilatation at high pressures inside the LED stent. We primarily didn't want to dissect the most distal landing zone because it was a diffusely diseased vessel. That was the reason why we went ahead with a 2.75 millimeter stent and deployed it at very low atmospheres at 12 atmospheres. Now that's the flow after that. Now our plan was to go ahead with stenting of the left main into LED overlapping with the first stent. Well, we didn't want to have wires inside the diagonal branch because based on OCT the angles were all looking good and there was no significant disease over there at the mouth of the vessel, so we didn't really have a wire inside the diagonal branch. Well, while putting a stent across the left main into the LED, we would invariably have a wire there, so that's what we are at right now. Next image. Okay, so this is where we are. So that's the live fluoro monitor. We have a wire. We just had a wire which that was again a Versatin wire into the circumflex artery, and now we are going with a 3.5 into 28 millimeter alpine stent. 3.5 into 28.
while you're doing all that, can someone, perhaps any of the OCT experts there, give us the lengths of the from diagonal 1 to ostial LAD and from diagonal 2 to ostial LAD, because that's another feature OCT gives us in this precision thing, help us understand precisely the lengths. So what kind of lengths did you get from those measurements of the OCT?
Well, the challenge that we had was the guide catheter was actually sitting inside the left main, almost 3-4 millimeters into the left main. So we wouldn't really be able to identify the ostium of the LED from ostium of the left main, so that the length measurement may not be really accurate. Well, we would definitely get an idea regarding the length from the ostial LED to the diagonal one, but I thought it was immaterial.
That's what I wanted.
Yes.
Yeah, that's what I'm interested in, because I have an alternative stenting technique to propose to you.
No.
To stent only from ostial LAD and on.
Just show the length from the ostium of LED till the diagonal ostium, first diagonal.
That's what makes a good discussion, to
So
have alternative options.
So you would want to avoid the left main stenting, is it?
Well, I think we're dealing with, let's convert now from the CTO and the OCT into bifurcation lesion. That's what this now is. We have a 0-0-1 bifurcation with a rather wide angle. And, you know, it is not impossible. The circumflex is huge. It's not impossible you're able to nail this ostium if you wanted to. Of course, you don't have to, but I'm saying that's an option, perhaps my option. And again, that's another good idea that, you know, precision PCI is not only precision in quantity of the calciums and the lumens, but also precision in length. And, you know, if we have this length, then we can calculate perhaps a 38 or a 48 stent might do the job fine, I guess, in my point of view. Then we can see where you end up.
Yeah,
Deepak, what was the left main diameter?
It was 4.5. So we are going with a 3.5 alpine stent, a 3.5, definitely you would be able to go more than 4.5. So that was the reason why we decided on a
Yeah.
3.5 stent. So what is other panelists' opinion? Would you really want to position it right at the ostium of
we
LED,
can
or
say
would you?
it's like from 70, quite frankly, until like 40. So it's about 30
Yes, it's around
for sure.
24.
So,
Yeah.
yeah, 24. So a 38 stent might be able to just cover the whole thing and spare the left main. Carlo, would you spare the left main? I think Dr. Di Mario would cover the left main, though.
Yeah.
Well, I mean, the discrepancy is very important, and
Very important.
of course, that will you never like to go from 4.5 to a relatively smaller
Overlap.
LED. Having said
Overlap.
that, there
Cranial.
is quite diffuse disease also in the left main. They have already implanted, isn't it, a stent that goes almost to the ostium.
And
At that point,
there
I
is
think
no
that
definite landing zone.
yeah.
There is no good landing zone for the stent for the LED ostium. And
12,
however
14.
best you try to do,
12,
it will
14.
always try to protrude into the left main.
Negative.
Oh yeah, sure it will protrude, but I'm just saying that if you protrude 1
4.5.
millimeter at the case like this one, not every case, this one, that the circumflex is 4.0 and wide open, I don't think it matters. So you can afford the little bit protrusion. You can afford 1 millimeter protrusion.
I mean, it looks nice. I would personally prefer the left cranial for implantation of a stent in the left main. What do you think, George?
You prefer
Left
what?
cranial for implanting a stent
Oh,
in the
left
left
cranial.
main.
Yes, it's true. It's true. We could, but I think particularly in this case, they get a good idea with the angulation of the catheter, etc. So I would say they're lucky
No,
to be able
no,
to
to
do it
look
here
at
as
the,
well.
yeah, probably to look at the left main ostium, that cranial would have been more better.
Yeah. It will be more precise, I would say. I guess that's again precise PCI. Maybe an extra look from the left LAO-cranial would be helpful here by the panelist. Dr. Davidson will give it to us on the next break. But essentially, the stent is implanted. We're going to go now with the high-pressure balloons, at least 3.5, I suppose, and then later on maybe a 4.5 by 8 or something in the left main to optimize the pot. Proximal optimism. It's all about pot now in this crossover technique that they chose. It's all about a pot.
14. Well, we have the wire inside the circumflex, and we have gone with a 4.5 negative. 4.5 millimeter balloon, non-compliant. That's an NC Trek. So we are going up at 16 atmospheres. Please go ahead. 16 negative.
16,
So we've
20.
done the pot
Very
also.
good.
Well, now we would check the circumflex ostium and remove the wire from the circumflex ostium.
Well, yeah, then you have to put it back in. You have to give me
Yeah.
an OCT of the circumflex.
Yeah,
I'm very curious.
The circumflex ostium angiographically, it looks reasonably good. There is no significant plaque shift. Well, we'll take out the wire from the circumflex and try to rewire it before we do the post dilatations of the distal as well as proximal LED with 3 as well as 3.5 millimeter balloons. Well, would you really want to? The circumflex looks good. Would you really want to do a kissing balloon dilatation at this point of time?
Well, we'll take a risk of dissecting. I mean, while you do that, I don't think there was much resistance in pulling the wire. So I wonder whether 4.5 was enough, in fact, in this particular case, to really jail that wire in
I
the
think the guy
circle.
has to sit a little bit better. Yeah, I think I would like you to give me an
3
OCT
and
of the
3.5.
circumflex because I like to see the mid lesion also.
Correct. Yeah, see, the only thing
Dr.
what we
Davidson,
can do
is
is,
too many things we're asking you.
Well, going with OCT without dilating, that will be a challenge, George.
No,
Well,
no,
let's
no.
see.
No,
And
the
anyway, we
point
were
is-
first to do the mid LED has not been done with high pressure balloon dilatation. So don't forget that the occlusion was in the mid LED. So that needs the special attention.
special.
18 to 20.
See, generally,
Negative.
let him do that NC
Cranial.
balloon dilatation of the mid LAD. For the final kissing, especially for a lesion like this,
14
if at all we are
വരെയൊക്കെ
doing
പോയാൽ
an
മതി.
OCT,
14
how we decide is, when we do a OCT, if you see a lot of struts across the side branch, like if you see connecting carina or many struts across the circumflex, then it is very good that you can dilate, do a final kissing. When you do a OCT, if there is no struts across the side branch, if the side branch is open or very minimal struts, probably I don't
14.
think there's any use of doing a final kissing balloon in such cases.
Negative.
So unlike when there is no OCT, when there is a
16.
OCT, you can take a decision based on that.
Negative. 60. 3.5 below. So what's the present consensus regarding the bifurcation after crossover stenting? Because based on the EBC main, when the trial was designed, it was a mandate, right? It was a mandate that any crossover stenting at the bifurcation had to be kissed and 90% kissing was done. So would you still advocate in this particular case that it's necessary, or would you like to see an OCT run across the ostium of the circumflex? If there are no significant links or struts over there, would you try to avoid doing a kissing balloon dilatation? What is your regular thought?
In terms of trial, you know better than me that there is nothing to indicate that kissing balloon dilatation for provisional stenting improves prognosis. So definitely that's not the case. I don't know. I think every case is different. It's a large circumflex. We want to make sure that there is no significant osteal lesion there. I could say maybe George is a bit teasing you, trying to push you to do a little bit more than what you normally do.
I definitely want to see the OCT. I want to see the OCT of the mid-circ as well as the ostium. And thank you for mentioning the EBC ideas. That's great. I saw all of you participating in SCAI. You put your fellow of SCAI in your credentials. Great to participate in the SCAI bifurcation as well. That's great. We definitely have to really think about the studies and the imaging more. Precision PCI and precision bifurcation, a new concept. So I would say we have so much done about OCT. Everything's going so smoothly, by the way. You are able to complete everything so quickly. Let's just do the OCT and we have time.
Yes, we'll do the final OCT run after this post dilatation. 16.
You do OCT, to both directions. That's great.
Would you really want negative? Would you really want to do an OCT pullback from the circumflex? We never try to go through the struts. We would always try to have a pullback from the LAD to left main, see if there are significant links or significant struts across the circumflex. Then we would try to get a balloon across and then do a kissing balloon dilatation at very low pressures. But if there are no please go ahead.
Let's do the OCT in the LAD now, so we can then we discuss afterwards.
Yes, we'll do.
All right, and absolutely. This is a great case, isn't it?
Absolutely. Any
cranial
question
OCT
from the
catheter?
floor?
Well, it was started as a CTO, then became a OCT calcified lesion, then turned out into a bifurcation. And then also ended up as left main. So it's 4 cases in one. Talking about precision PCI, and all the side branches are there's so many side branches, all of them very important, and all of them widely patent. Tremendously successful procedure, very rewarding.
I hope we have another.
That's why we keep asking him for more. The more he does well and so quickly, we want more to fill the time.
I hope we have another 5
dynamically.
more. I hope we have another 5 more minutes for the OCT to be completed, right? We are going.
Yes, we have 5 minutes for the OCT, absolutely.
Yes, the OCT.
You know, while they do that, George, I mean, left main in the US almost automatically means impeller. So here there is a normal left ventricular function, you won't consider that.
No.
Hemodynamically remains extremely stable.
I will not, but I definitely back out the guy though before the OCT. Oh, actually, I don't know how the OCT is going to work. Let's see. Let's see how it works.
Okay, that's good.
Deepak, have you done the recrossing of the wire?
Yes, sir. We just
Yeah.
pulled it out,
Yes.
and after the pot, we pulled it out and recrossed. It went in without any difficulty.
Yeah.
Right.
Yeah, let's go with the
Deepak?
OCT
Yes, sir.
live.
Deepak, we need to see the ostium of the left vein also. Do you follow any special technique to
Sir,
see the
when we
ostium
really
of
want
left
to
vein?
see that, when we really want to see that in osteal disease, we go with a telescope catheter, guide extension, and then try to do that. Here,
Yeah.
angiographically,
Okay.
the ostium looks really good, so we thought that probably we should avoid using a guide extension
Yeah.
catheter. Okay, you're
Okay,
ready?
go ahead.
You're ready?
Let's see.
Live view, 70. No, we need to have long run to cover both the stents. Anisha, small perch. Okay, 75 would be fair enough. Okay, survey mode is fair enough. Okay, auto calibrate. I'll say inject and activate. Okay, so please go ahead. Okay,
Good. Go ahead. We have exactly
Inject,
3 minutes and 15
activate.
seconds. Tremendous. Oh,
Okay,
beautiful. I can
that's
just see it. It was all good.
Okay, precious.
It was all good. Tremendous circular expansion pretty much everywhere. There's a minor protrusions here and there. What can you do about those? This is just the great and a very nice tapering.
Okay, well, I'll come to that. Well, we have actually landed proximal to that particular diagonal branch, the D2, the big one that we saw in the retrograde injection. Well, as we see that particular area beyond the stented segment, there appears to be there appears to be no dissections or any complications there. Then, if you look at the apposition marker, it looks good. The apposition has been reasonably good. Well, we'll also look at the extent expansion also. But prior to that, as we come more proximally, I would want to go to the bifurcation mode just to see the circumflex ostium. That's the circumflex ostium. We'll just go to the circumflex ostium bifurcation mode.
Yeah, just rotate.
Well, that's the circumflex ostium. We are very fortunate that
Yeah,
there is.
excellent.
Yeah, we are very fortunate that there is
Only one.
there is no significant links over there. We are just seeing the crowns seated over there, but there are no links. And you could also see that the wire has gone into the side branch through a more proximal cell. If at all we would want to do a kissing balloon dilatation, we would probably take another wire and go through the distal cell so that we'll have a proper scaffolding of the circumflex ostium. So here I personally feel that we needn't do anything for the circumflex ostium because it looks good. There is no links across the circumflex ostium. There are only crowns sitting over there. So what is your opinion regarding that?
Yeah, leave it alone. Both of us vote same, no, Carlo? Leave it alone.
Yeah.
Show us now the circumflex.
Oh, would you really want to have a pullback?
No.
The ostium of the circumflex is the question. Is this the ostium of the circumflex or the ostium of the diagonal?
No,
No,
this
it's
is the
the
ostium of the circumflex. That's the circumflex ostium, the wire going into the circumflex. The diagonal, I'll show it to you in the longitudinal image.
I see. Okay. No, fair enough. No, I'm saying, you can leave it. Definitely, I think I will not do anything. But since we're doing precision PCI, you're going to do the OCT after we go off camera, and you're going to email me the result about the mid lesion and the ostium.
Yeah, you can see.
Personally, I'm curious, but doesn't have to be part of the live case. We can successfully complete it on time.
we
And you
can
did a
see
great job. No need.
one diagonal ostium over here, which looks really good. Then as we come more proximally,
Also lack.
Precision.
Yeah.
Precision, that's what I call it.
The position of the struts is unpredictable, however.
It's a tremendous precision.
and that is again at another diagonal. So the diagonal ostium looks really good. So
Great.
probably would you want to do something more? We thought we should stop the procedure with some nitro final shoots and stop the procedure.
We can definitely stop the live case, but part of the procedure. That's great. You did a tremendous
Enlarge the
result,
cameras.
and you are able to handle all the difficult questions we ask you with a tremendously charismatic way. Thank you. Congratulations to you and Dr. Joseph for putting a masterful presentation together. And we thank Dr. Salvamani, as well as we thank all your assistants who you named, Dr. Nisha, Dr. Dinesh, Dr. Anisha,
That's
and many
great.
others that we see there.
That's great. You
Carlo?
tend to remember everyone's name. We also have
Remember the names.
few more guys over here. The Abbott guys also supporting us with the OCT.
Dr. Jojo, of course. Where is he? Yes, of course.
That's really great. Now we have Lijo as well as Sharath also with us. Thank you so much. Thank you once again.
Thank you for transmitting late at night. Thank you.
Tremendous. Thank you. And at this point, I think we conclude successfully this session.